because optimum outcome of a patient, which is the prime target for all of us, is teamwork, the communication, mutual understanding, of course the mutual professional trust, because if trust is not there, it's not going to be there. What are our expectations, and you know better than me, that's a part of your curriculum. In pre-operative phase, you are supposed to be assessing the patient for baseline measurement, in the sense that the strength of the muscle or any deficit, anything for that matter, the functional activity of that patient. Of course, you are going to educate the patient about post-operative rehabilitation goals, what he or she is supposed to do, and then setting the realistic, not unrealistic expectation, and also the expected probable recovery timeline, not necessarily fixed timeline, because every patient behaves differently. In post-operative phase, early mobilization protocol and adherence to the protocols, effective pain management strategy equally important, whether applying ice or cryotherapy or whatever, you know better than me. And of course, customized rehabilitation protocol depending upon the type of the surgery, ACL, TKR or any other for that matter. And simultaneously your target is to avoid the preventable complication like stiffness. If you're not going to be acting in time or delaying, we are going to have complication, stiffness, and that is very difficult to handle subsequently, especially like injuries or surgery around elbow and knee. And once the stiffness happens, if you're not quickly acted, which you should have acted, then the things are going to be difficult. Your role is immense in chronic condition also, like osteoarthritis, low backache, tennis elbow, golfer elbow, frozen shoulder, rotator cuff arthropathy, plantar fasciitis, and many conditions. We are not able to deal, but you are able to deal better. So what do we expect from you? A communication from you, a clear communication, update to the surgeon on the patient progress, especially if the things are not progressing well. Reporting in a red flag. What is a red flag? If there is an infection, immediately report patient back. Then you don't have to continue with the physio. Unexpected pain, that means something has gone wrong. And you must be using standardized tools for progress tracking, like range of motion measurement or functional score, so that you can speak same language across. You can communicate the range of motion of 0 to 100 degree or 0 to 40 degree, or for that matter in the knee, if you're speaking 5 to 20 degree or 5 to 50 degree, so I would know there is a fixed flexion deformity and there is also a subsequent this thing. We also expect from you is professional competence, so we expect from ourselves as well, from our colleague, keeping updated with the latest evidence-based practices, understanding the surgical technique, limitation of those techniques. Particularly, this is most important for you, and there is a conflict actually, particularly I have got an issue at times. You have to understand what are the surgical procedures. You don't have to do that, you don't have to go into the technical details, but grossly you should be knowing the techniques, their limitation, the load restriction and post-operative. Because when it is nail, the load restriction is different compared to when we are using plate. Upper limb is different compared to lower limb. So you have to understand. And you have to have a collaboration approach, as I told you beginning, during the follow-up, to ensure the realistic progression. So what are the challenges in collaboration? There are challenges. This is what expectation from our side, but not necessarily everything is so good as you were asking or telling other. So what challenging is misaligned expectation. We expect something different, you expect something different, and we are not following the same route or direction for that matter. Of course, there is a variability in physiotherapists, and so are the surgeon's expertise as well. Not necessarily you are the only people, but obviously when I am asking right now, the question is expectation from you people, so that is the reason I put this. So the most important is communication gap. In ego clashes, the bigger killer is ego. Why should I be communicating to an orthopedic surgeon? And orthopedic surgeon says, why should I be communicating to a physiotherapist? And there the problem lies. There is absolutely no harm in communicating with each other. And another issue is non-adherence to the post-op protocol. Example like starting aggressive mobilization or weight bearing too early against the surgeon's instruction. Very wrong, not a good news. Impact, it is going to risk of complication like implant failure, delayed union, stiffness, and this is going to invite even medical legal issues for you. What is expected out of you? Follow the surgeon provided rehabilitation guidelines strictly, because surgeon only would know the quality of bone, the quality of fixation, the type of surgery. Over or under treatment, that is another issue. Example, excessive exercise leading to pain, inflammation and delayed healing. Under treatment, minimal or delayed rehabilitation causing stiffness or muscle atrophy. What is the impact? Poor functional recovery or prolonged disability. What is expected? Tailored therapy based on the type of surgery and particular patient in collaboration with surgeon. Ignoring surgical consideration. I don't care, I have to go for ahead with whatever I know. Example, not understanding the surgical technique, like type of implant I told you earlier. Treated a lock plate fixation like a standard ORIF. This is a different protocol altogether. Ignoring the load restriction, most important. If you start early weight bearing, ignoring the surgeon's choice, you are going to invite implant failure, breakage of plate, and that's a huge negative. You don't want to invite that. This will lead to stress and surgical repair, leading to complication. You are expected to be aware of the surgical procedure and their implication in rehabilitation. Inconsistent treatment technique, that even we also suffer through that. Variability technique across the different physiotherapy, we don't speak the same language because we do not follow the protocol based training, or for that matter protocol based approach. So this will lead to confusion in the mind of the patient and inconsistent outcome. You are expected to follow a standardized, a national, internationally based protocol, scientific evidence based. It is not what I teach or what a senior person teach or junior. Whatever is written, established books are being followed worldwide. That's you. At times this is another controversial issue actually. Dr. Ejaz rightly said yesterday, and even Dr. Musarat also, I think he mentioned about yesterday during his talk, overstepping the boundaries. Modifying protocol without consulting surgeons. Giving medicine about the medication or surgical decision, giving advice. This is impact, mistrust and potential harm to the patient. So expected is to remain within the scope of physiotherapy, remain within the boundaries and practice what you know the best, and involve the surgeon if and when necessary. Another is at times there is a delayed initiation of rehabilitation, waiting too long, that is going to lead to complications, stiffness and that. You are expected to act at the time when it is supposed to. At times focusing only on the short term gain, both in financial term as well as in symptomatic relief, ignoring the long term endurance and the muscle strengthening and the functional rehabilitation. There is another controversial issue, and that's a debatable worldwide, not necessarily here. Should the physiotherapist be a primary or a secondary healthcare provider, the contact person? But there are advantages, disadvantages. When you talk of primary physiotherapy contact person as a physiotherapist, advantage is early access to the care. It becomes more cost effective. And what is the global practice? There are direct access in UK, Canada and Australia, and that's quite successful. But that is strictly adherence to the protocol. These are the indications where the physiotherapist is directly going to act, and if these are the red flags, he or she is not going to acting, directly referring to the orthopedic surgeon and then coming back actually. So what are the challenges in primary control? There is a risk of misdiagnosis, because you are not supposed to be trained enough to diagnose all the problems, because that is not desired, because that is not within the standard protocol. There is a limited scope. You cannot prescribe medication, and at times cannot ask for even imaging. There is also safety concern, medical legal issues, complex case need surgeon input for accurate treatment. What is secondary contacts? Referred by an orthopedic surgeon and then you see the patient. Advantage, better diagnosis invariably as the first. Comprehensive care because you are collaborating and will have a structured protocol. Challenges, delay in recovery, overburden of surgeon is going to see more number of patients, and obviously it is cost wise also it increases. He will have at least minimum, he will have to pay the initial consulting fee to the both people, and that's also not. This is a quick comparative table. I'm not going to go into that detail. What is the evidence? When the primary contact is effective, when there is a minor strain, back pain, postural issue, but there should not be any red flag. You need to know what are the red flag signs. When I'm talking just a backache, there are clearly described red flags. You should not be touching before referring it to the orthopedic surgeon. When the secondary contact is necessary, like trauma, significant trauma I am talking of, not minor trauma, fractures, infection, deformity or any suspicion of malignancy. Optimal patient care requires the right provider healthcare person at the right time. So collaboration model is the best. There's a dual role with clear guideline, clear responsibilities. Physiotherapist as the primary provider for non-complex cases and refer to surgeon for any trauma, infection or any red flag sign. You have to have a shared type of care plan, jointly managed, example for the ACL rehabilitation pathways. So what are the strategies to overcome these challenges? We need to have more of it. Like this is since yesterday, this is an example of giant meeting, training session and share. It's going to happen if you start communicating with each other. There is absolutely no problem in that. Have better communication. Try to practice evidence rather than eminence based that I do this way and this is working. No, it does not. Evidence, when you start practicing evidence based, invariably it is reproducible. It is going to work for you, it is going to work for me, it is going to work for any person. If you start practicing self-type, then it's not going to work. It may work in 10 cases, but it is not going to work in another case as well. So collaboration is the cornerstone of successful orthopedic rehabilitation program. In conclusion, both roles are very essential. Mind you, it is very essential. We are not here to replace each other. We cannot. It is depending upon the case scenario actually. Effective healthcare provided is both the right provider at the right time for a right patient. It is not about me or I. It is about we. An orthopedic surgeon is successful only if an efficient physiotherapist is backing him. Thank you very much. Thanks a lot. Thank you. So we are all here for one purpose, patient. The patient is best educator, best teacher. We are earning livelihood because of the patient. We are having respect, recognition, prestige because of the patient. And if you don't put his or her interest at the forefront, we are certainly deceiving ourselves. We are becoming unethical, of course, cheating ourselves. As I told yesterday, we are believed to next to the God, and God does not cheat, right? So that is as simple as that. You have to remind. Last very controversial issue also I'm going to just touch with due respect. I think we should avoid, I'm not saying endorsing that someone must be doing, obviously most of 99% you people are not doing, but no cut commission practice also. Because that's also very, very wrong. I mean, if you start with that, trust me, in short term you will be gaining something, in long term you are ruining yourself, you are ruining your profession. And that's also very, very wrong. See, let me tell you very frankly, if we start believing, first of all, have self-belief, respect, have pride in your profession, whatever you've chosen, practice that with the hard work, acquire knowledge, skills, hard work, skills and soft skill, work hard, definitely, and work both with heart, putting your heart and soul. You're definitely going to be there. You will be rewarded with money, with name and fame, professional satisfaction, and everything will be there. And the very good news also I'm going to tell you is, we are in a population, there's an immense scope. You are just in an infancy, physiotherapy. In the rural India, hardly people know that. And majority of us in India is the rural India. It's still, I think 70% is rural India. So a number of patients is absolutely no dearth at all. We should not be scared of this thing. We also need to remind ourselves that destiny is fixed. Nobody is going to take away your path. So start believing in yourself, have pride in yourself, practice evidence-based, practice better, and the sky is the limit, trust me. Dr. Jaz, would you agree with that? So I think that is it basically. Any question, any controversy further? Shall we find out? Thank you very much. Thanks a lot.
Thank you guys.